So today's program is sponsored by Alexion and EMD Serono, and I would like everybody to give them a round of applause and say thank you. Dr. Subei has been practicing, I think you started in neuro-ophthalmology, yes? Okay, so he started as a neuro-ophthalmologist, went on to become a multiple sclerosis specialist, and he's here today to discuss with you many things about multiple sclerosis, including the basics of NMOSD, GMG, MOGAD, optic issues in MS and the other rare diseases. And he's going to do all this in 45 minutes. And then we're going to open up the floor to Q&A here and online. Okay? Thank you very much.
Thank you, Stuart. Thank you for having me, and I really appreciate you putting together this program. The goal here is for us to provide education for patients out there, whether you have MS, NMO, myasthenia gravis, any autoimmune disease. It's always great that patients understand their disease because it helps you and it helps us come together and come up with a treatment plan that even goes beyond just medications. So Stuart wants me to talk about what I can cover in 12 hours in 45 minutes. So let's see if we can do this. And it's me against the chicken. All right, I am a speaker for several companies, and so I just wanted to let you know I will be talking about some of the products that I do speak for. It's always good to kind of give a baseline and set the stage. So the immune system, if we really wanted to simplify it, it's divided into the innate immune system and the adaptive immune system. The innate immune system being present day one when someone is born, that immune system is available to fight off infections. The adaptive immune system is the one that learns. And so as we get exposed to different viruses and bacteria or vaccinations, the immune system will learn, create a memory of that, so that way then it can fight off later on. And now this is the part where we can get into trouble, because that adaptive immune system, sometimes as it's developing an immunity against whatever it was exposed to, will recognize the body as foreign and then cause the attack there. And depending on where these attacks happen, so we either get multiple sclerosis, neuromyelitis optica, myasthenia gravis, or a whole bunch of other autoimmune conditions. So we're going to start talking about MS. And again, simplifying things, it's an autoimmune condition where we have activated lymphocytes that are in the periphery, in the bloodstream, and then they break the blood-brain barrier and they enter the CNS compartment. It's a disease of the brain and the spinal cord, okay? And so brain, spinal cord, this is where we see multiple sclerosis, and those are the areas that we typically investigate. And we have multiple medications, starting in 1993, when we had our first MS medication, and then up until now, there's maybe about 26 or 27 different drugs. And we started off with interferons, glatiramer acetate. Those are the older injectable medications. We have our fumarates, and those medications kind of shift the balance between proactive inflammatory cells and less active inflammatory cells. We have our S1P receptor modulators. Those are the medications that will trap the lymphocytes in the lymph nodes so they can't escape. And we have several different medications here, some selective, some not. And then we have our B cell depleters. Those are medications that will take away part of the immune system, the B cells. They're the ones that activate the other cells and lead to that inflammation cascade. We have medications that are not selective, and so they will target both B and T cells, take them away, deplete them, and then the body will make up new cells. And those will either come in IV or oral. And then we have medications that work in a unique way where you can't put them in a category. And so whether that's sealing that blood-brain barrier so that the cells that are active cannot enter and cause damage, or cells that will prevent the medications that will prevent cells from multiplying so that proliferation discontinues. And so we decide on the medication, using a lot of factors. And so there's not one medication that works for every single person. And it's up to the physician and the patient to sort of come up with the best treatment strategy depending on what the patient has gone through. It's very important for us to understand why we're taking the medication. I'm going to take a step back and I'll give you an analogy that I've given to many of our patients. Multiple sclerosis is like you have a bunch of kids that are egging your house, okay? So And now with the price of eggs, you think about it. So they're grabbing the eggs, they're egging the house, okay? Then the symptoms happen depending on where the house was egged. So when we are treating MS, we are treating the kids that are egging the house. The house is still egged. Okay, so our medications for MS are treating the immune system, not the neurological system where the symptoms have happened. So when patients ask me, well, I started this medication and I don't feel better, I say, well, you're not supposed to feel better. Or I get patients that say, as soon as I started this medication, everything went away. Well, that's great, but it's not supposed to do that either. So number one is our goal is to stop attacks and relapses from happening. Number two is those lesions that we see on the MRI, we don't want to see anymore because those are evidence of attacks that have happened. And then number three is we know that there's a slow decline that happens in MS patients. We are trying to push that out as much as possible. And so if a medication is doing those three things, then I say we've got pretty decent success. And if we're not, then okay, we need to change the strategy. So we are not changing symptoms. We have other medications that address symptoms, but they don't change the immune system. And then we cannot repair. We still do not have that repair mechanism yet. And then reversing disability. So this is the part where I put a little asterisk in there because some of our more aggressive medications can actually quiet down the immune system enough for some repair and reversibility to happen. And so we've seen some data on disability improvement with some of our medications. So things to consider, when I meet a patient, I'm trying to understand what their disease is like. How active has it been? Whether it's number of relapses, MRIs, what their physical exam looks like. So the clinical course, how many relapses they've had, whether they think that they're declining or not, progressing. If they have other medical conditions or medications, because those can interact with what we're doing in conflict. If someone has exposure to other viruses or things that we have to be on the lookout for, whenever you're messing with the immune system, there's always going to be a consequence, and so we want to be sure that we're doing that in the right way. And then adherence and reliability. I've actually put patients on great medications, and then I took them away because patients were not showing up to appointments. They're not getting their blood work done. They're not getting their imaging. So this person is going to be at risk for infections and serious conditions. And so I can't put that risk on the patient. So I have to take away the medication and put them on something milder that won't require all that monitoring. And then there's obviously, we talked about this, risk of infections and then requirements for vaccinations. We know that the past several years have not been easy. We've had to take some vaccines, and then whether we are able to mount a vaccine response when we're on immune therapy or not, that depends on a lot of factors. And then obviously there's patient preference, there's their experiences and the people that they know that have tried so-and-so. And so we take that all into consideration and we try to make the right decision for each patient. So let's switch over to a little bit of a grimmer note. We know that the typical course for MS is relapsing remitting for most patients, where they get an attack, it goes away. They get another attack, it goes away. Sometimes the recovery is really good. Sometimes the recovery is not so good. But we also know that there is progression that happens. In the past, we used to think that it's kind of like a switch where, oh, now I'm relapsing remitting, and then at some point I become secondary progressive. That's not true. Progression starts from day one. It's just we can't capture it. We can't notice it until time has gone by. What I'm showing you here is older studies before we had really great medications, but it's showing you that a good percentage of patients will become disabled about 17 to 20 years into the diagnosis. But maybe we can push that out further now with our newer medications. So if you also think about the time that it takes someone to need to use a cane or become dependent on a cane or some assist device, in the past it took about, again, 15, 20, 30 years or so to get that requirement. And that depends on how active the disease is. And remember, a lot of this data is before we had great MS medications. In fact, if you look at this, so 15 years, but this study was done in 1989. Okay, so things have really are starting to change. But it's important for us to be aware of this. Why? Because when patients say, I feel great, I don't need to be on medication, and and I'm afraid about side effects. And I say, okay, well, if the side effect is 1% or less than 1%, but what is your risk of disability if you're untreated? We know the disability is 60% will be disabled in 15, 20 years if you don't go on treatment. Natural history of the disease. So you really have to understand this. Then we dive into a little bit of a detail and think about disability. When someone has an attack, optic neuritis, transverse myelitis, a brainstem relapse, whatever symptom they develop, they may recover completely or they may not necessarily recover completely. We call that relapse associated worsening because the patient worsened as a result of a relapse. Okay? So technically, if I stop relapses, do I stop worsening? We think that's true, but not entirely, because there's something called PIRA, progression independent of relapse activity, which means that progression happens even though someone is not having relapses. And so when we, over the years, you think about the past 15, 20 years, patients come to our office and they say, Dr. Subei, I'm on medication. My MRIs have not showed any change. I've not had any relapses, but why am I worsening? Why am I getting worse? And that's because of this concept called PIRA. And this is something that has surfaced in the MS community, I would say within the past 5 to 10 years. So a large study was done, and they went back and they looked at all the clinical trials that have been done over the years, and looking at how many patients had relapse-associated worsening and how many patients developed PIRA, or progression independent of relapse activity. And if you look on the right-hand side, these were patients who were on treatment. These were patients who were not on treatment. So in the clinical trial, just like a lot of trials, you get randomized into you get this or you get that, either active drug or placebo. And they look at the people that had that progression on relapses, on treatment, and those who had progression off treatment. And there is PIRA in both. Obviously, it's a lot less in those that are on treatment, and so a lower percentage, but than those who are not. But it still happens. Okay, so we know that PIRA happens. But let's put a little bit of a positive spin on this. So if you look at over the years with our treatments and as we're managing patients, and the EDSS is a disability scale, and so every patient, we examine them in the clinic and we give them a number. This is what your disability scale is. Over the years, our disability scale has improving, and so we are making a difference. Okay, it's not entirely coming down to 0, but it may be dropped from an average of 4.2 to a 2.7. Okay, so our medications, as we're evolving and coming up with newer medications, it is starting to make a difference. When you look at the percent of people, so this is looking at prevalence of patients with secondary progressive MS. So that's that categorization where they're not having relapses, but they're having slow worsening. And the prevalence of SPMS is decreasing over time. Okay, so our medications maybe are making a difference. Maybe it's not completely medications. Maybe it's the fact that we are diagnosing people earlier, getting them on treatment earlier, high efficacy treatment earlier. And so it is making an impact over years. Then you look at the incidence, is how many new cases every year we are getting of secondary progressive MS, and that is coming down. And so again, with the earlier diagnosis, more accurate one, getting on high efficacy treatment early, we are making a difference in that progression. The age, so how long or how old patients are when they develop progressive MS. So it used to be a lot earlier, and now again, because of a lot of changes, that age is increasing. And that's what I tell patients is we're trying to get ahead of the game where if you start to notice any symptoms, we say, okay, well, is this aging or is it MS? And that's a great place to be in because then, you're not going to be able to beat aging. None of us can. But if we can beat MS, then that would be a great achievement. So why is this happening? Okay. And I've tried to put the same diagram that I had shown earlier with this showing you the blood vessels because MS, we think of it as the outside in. And so this is a condition where active immune cells are in the bloodstream and then they break that blood-brain barrier and they enter. There is something called a compartmentalized inflammation where you have these microglia that are creating compartments. And the issue with our current treatments for MS is that a lot of them are too big and they stay in the bloodstream and they can't enter the brain. Okay, so if I put someone on a medication and it's taking away their immune cells or shutting them down or turning them off, then there's less immune cells in the bloodstream, which means eventually less immune cells entering the brain and causing, the demyelination and the axonal loss and everything else. But what if this has already happened? And this is why when patients go on high efficacy treatment later on and they say, well, it's not working. Well, that's because too late. These guys are already in the brain and we can't reach them. So there's something called paramagnetic rim lesions that we now know where because of that compartmentalized inflammation, there's a breakdown of blood products and iron that are in there. And so you can do specialized testing. A lot of this is not available commercially, but you can actually identify those chronic lesions that you cannot reach. So going back to my analogy of the kids egging the house, those kids are inside the house and you're outside and you can't get in. That's the issue that we have right now with our medications. So then you try to think, okay, well, do we have any therapies that can enter the brain or make an impact? We have a couple that we think that can do that, not all medications, but we're trying to shift our focus now. We've done a great job at shutting down the immune system in the bloodstream. So we've got a lot of great medications. I've listed many of them on my slides, and those do a great job at quieting down the inflammation in the bloodstream. But what about inside the brain? But before you get to that, how can I tell if someone is worsening or progressing or declining? Because you got to be able to measure it. And our neuro exam, we can do this all day long. You guys are all familiar with this. It's not sensitive enough. And so if someone has a 4+ strength, a 4 minus, am I going to be able to remember that and tell the difference? Oh, today you're a little bit of a 4 minus, you were a 4+. And so we need to use something else to be able to capture that disability and change. And so the EDSS is the scale that I told you about. We do a neuro exam and we put a number to it. It's not as sensitive as we would like it to be. So then you have a timed 25-foot walk, and many of you are familiar with this. And so we measure how fast it takes someone to walk 25 feet. And that we can measure and follow over time. And we can say, oh, well, your 25-foot walk is still within target, and so it's not changed. Okay, great. We can do a 9-hole peg test, and so we time how fast someone can take 9 pegs, put them in one at a time, and then take them out one at a time. A symbol digit modality test is a cognitive test. So how quickly you can match symbols. And so it gives you a key, and then you're supposed to figure out, oh, this one is a 3. I'm not doing a great job. 2. So on and so forth. Okay, and then you can see how many you're able to do in that minute and a half, and then follow that over time. There's patient-reported outcomes, and so we can ask patients, how have you been feeling the past couple of weeks? And then you can use that to follow over time. And actually, that tees up an answer to a question about cognition and mental health in MS, because this is where you pick it up. And then OCT, if we measure the thickness of the optic nerve, because we know that the optic nerves are an extension of the brain. And so then maybe you can follow that over time and see if there's any change. And so probably it's not one of these. It's the combination of things where you kind of put it together. And I sometimes like to ask a patient is, how do you compare yourself to last year? How do you compare yourself to 5 years ago, to 10 years ago? Are you the same, better, or worse? And if you are, in what way? Because there are a lot of other factors that can contribute to someone feeling worse. But what I'm trying to do is I'm trying to capture any sense of progression to see if I can make a difference in that case. So now that we've sort of talked about this, we have some upcoming medications. A lot of research has shifted focus into that progression and compartmentalized inflammation to try to see if we can make a difference. We have a class of medications that we've been investigating for a while, BTK inhibitors, Bruton's tyrosine kinase inhibitors. And those are medications that will work within the bloodstream and also within the brain compartment. We think that they are small enough to be able to enter the brain. And so whether they're decreasing the inflammation in the periphery, in the bloodstream, decreasing the chance of cells entering the brain, and then also helping with, repair and decreasing inflammation within that compartment. Okay, in theory, sounds great, right? But you won't know until you put a medication to test as to whether your theory proves right or wrong. Several different products are in research. We have evobrutinib, tolebrutinib, fenebrutinib, remibrutinib, orlabrutinib. Of course, these are not brands, and so that's why they all sound the same. And they're in different phases in their trials, whether they're for relapsing MS, progressive MS, that depends on the medication. 2 of them have completed their trials already, and then we have 3 others that are ongoing still. So, well, why do you need 5, or why do you have 5? Aren't they all the same? They're not all the same. Chemically, these are each different compounds, and how they interact and what receptors they work on differs and changes. And so you can't say that the results of one can be the same as another. So evobrutinib was in a clinical trial against teriflunomide, and our outcomes are always about relapses. And so the FDA requires us to use relapses as an outcome for every medication before it comes to market. And in this case, evobrutinib and teriflunomide were no different in decreasing the rate of relapses. Okay, and so this was not enough for it to pass the FDA's approval because it was no different than teriflunomide. I'm going to use my words carefully. It does not mean that it didn't work. It didn't work better than teriflunomide. And so if you look at the relapse rate, it's still pretty low. I mean, 0.15, 0.14. That's a relapse once every 7 or 9 years. And so it's much better than the untreated person, but not better than what you're comparing it to. When we look at progression and disability over time, there wasn't really a difference between either medication. And so unfortunately, this medication was scrapped. The next one is tolebrutinib. So this one was also pitted against teriflunomide. And in this case, the relapse rate was also similar, where there was no difference between being on teriflunomide or being on tolebrutinib. And so similar results. But when you look at the progression, there is a difference in the progression over time between those who are on tolebrutinib and those who are on teriflunomide. 29% less chance of progression at the end of the trial. So that made a difference. Now this result is in the relapsing trial. So then when you look at the non-relapsing trial, the secondary progressive trial, this is tolebrutinib against placebo, and you also see a difference where you're able to decrease the risk of progression, confirmed disability progression at 6 months, 31% less reduction. So based on the data from these 2 trials, we are hoping that we might see tolebrutinib soon. When they looked at the disability improvement at the end of the trial, there was also a favorable outcome for tolebrutinib at the end of that study. And so there might be something there because this is the first medication tested in a non-active, non-relapsing, progressing patient, and it showed that it made a difference in disability progression. And so a press release came out, and the FDA is granting breakthrough therapy designation, which means that they are going to come out with a decision September 28, 2025, and we'll see if this medication gets approved or not by the FDA. So this may be a promising treatment for patients with progressive MS, secondary progressive MS. So we still have other medications that are still in trials. Tolebrutinib is still in a primary progressive trial, so we still are waiting for that result. Fenebrutinib has a couple of trials in relapsing MS and primary progressive that will be coming out soon. And then remibrutinib is in its current trial, and that's still ongoing. And we are a site for this trial. And then orelabrutinib still has, this is a phase 2, and so they're not even at phase 3. So that's going to take them a while. Now, frexalimab is another medication that's currently in research. And basically, I focused on the phase 3 trials. If you search clinicaltrials.gov, you can pull up all clinical trials around the globe. And so that's what I did. And so I filtered by phase 3 trials for MS, and that's what I'm showing you. So frexalimab is a monthly infusion, relapsing MS, non-active secondary progressive MS. So this one is a CD40 ligand inhibitor. So what it does is, we know that if we take away B cells, it works really good at shutting down inflammation. But what if you keep the cells in there, you don't take them away, but you stop them from activating each other? And so this is the focus of this medication. And with this, using this receptor, we're able to affect both the innate immune system and the adaptive immune system. And so that microglia that's causing that compartmentalized inflammation, maybe we're able to target it through this mechanism. And so we're also a site for this trial, and we'll see what happens with it. This is the next one, vidofludimus calcium. So it's in a phase 3 right now, looking at relapsing MS. This medication is kind of similar to an existing medication that we have, preventing the proliferation of cells. But the difference here is that this molecule is small enough that it can enter the brain compartment. And they've already published some data in their phase 2 to show that they're able to slow down progression. And so this is another upcoming medication that we're excited to hear about. Stem cells. Many of you have heard about stem cells in MS, and that's a long discussion. But basically, there's a specific way or a right way of how to do stem cells, and there's a lot of other places that are not doing stem cells the right way. Put it that way. So, but there is a large trial that's called Beat MS that's basically looking at stem cells versus best available treatment. And the way that stem cells are done in this method is that they extract the blood, they isolate the stem cells, and then they blast the body with chemo, take away all the immune system, and then they put back the stem cells in for the immune system to kind of regenerate. And so this is a 3-month process to do all of that. The studies so far that have shown that there's efficacy to stem cells, a lot of them were either compared to much older medications, not so much of our newer medications, or there's some issues with the blinding, because it's hard to come up with a blinded study when you're doing stem cells. Patients for sure are going to know what treatment they're on because they're getting stem cells and chemo. And so we're going to shift gears here and talk about NMOSD and MOGAD. Okay, we used to think that NMO was a subcategory of MS. And then ever since 2005, when that aquaporin 4 antibody was discovered, and now we know that it's a completely different disease. And then within NMOSD, MOGAD was born, which is what looks like NMO, but then there's a different antibody called MOG-IgG. The difference here, and you have to, they're all autoimmune conditions, but how they work and where they work, that's what distinguishes one from the other. So in NMO, we're still talking about brain and spinal cord, but the difference here is, and I'm showing you the same picture exactly so that it kind of be the same message. You have astrocytes that are your guardians for the blood-brain barrier. And in this case, on their feet, they have water channels that are called aquaporin 4. And in this case, the immune system, in its defense against other pathogens, it creates antibodies that will see the water channel and attack it. So the damage is directly on this water channel, and that's what we're testing for. So when we send, she mentioned the cell-based assay, that's testing for antibodies that recognize the aquaporin 4 or the water channel. So I flipped the picture around and you're seeing the bloodstream with the antibodies, and now they're attacking these astrocytes and their foot processes. And during the attack, they will bring in immune markers called complement, and they will create a ring called the membrane attack complex and burr a hole into that blood-brain barrier in the astrocyte, and that's how they cause the destruction. Because of how this works, this is why relapses are much more severe in NMOSD than they are in MS, because it's not just taking away myelin and destroying some of the axons underneath. This is destroying the astrocytes completely, and so the recovery is not as good as it is in multiple sclerosis. But at the same time, in this condition, there is no progression. It's only relapses. So if you stop the relapses from happening, you pause the disease at its point. Now, contrasting that with MOGAD, and I know that this picture is really hard to read, I'm still showing you that the immune system comes in and these astrocytes are broken down and destroyed because of the antibody recognizing the aquaporin 4 channel. On the flip side, in MOG, these antibodies are coming in, but they're destroying the oligodendrocytes, okay? And so it's a little bit of a different target, but the symptoms look similar to NMO, where you have optic neuritis, a myelitis, or other cerebral or brain lesions that are being affected as a result of that. The difference in MOG is that it tends to respond to steroids favorably, and the patients recover really well. In NMO, they don't recover that well. In MOG, they recover very well. Most MOG patients have a monophasic disease, which means it's a one-time event that happens. A few of them have relapses where they come and go. With NMO, it's 100% relapsing remitting. We know for a fact. If you find the aquaporin 4 channel, this patient is at risk for further relapses, and we need to act. We do not have any FDA-approved medications for MOG, but we do have for NMO. Now, in terms of the locations, and so this is showing you the optic nerves, and you can see in NMOSD, there's a lot more involvement of the optic nerves, whereas in MS, it's a shorter segment of the optic nerve. NMO tends to be bilateral, just like it is in MOG. When you look at the spinal cord, in MS, it's only smaller portions of the spinal cord that get inflamed, like a transverse myelitis. But in NMO, it's a much larger portion of the spinal cord. Again, that's why the condition is much more devastating and severe if a relapse were to happen. And then involvement within the brain, where we have these lesions in the brain throughout in multiple sclerosis. In NMO, it tends to be other territories, and same thing in MOGAD. So they look a little bit different on MRIs as well. Now, we have 4 FDA-approved medications for NMOSD. Soliris, Ultomiris, those are complement inhibitors. We have Uplizna, which is a B-cell depleter, and then we have Enspryng, which works on IL-6. So basically, in that pathway that causes the destruction in NMOSD, these medications work in different areas to sort of quiet down. Now, I'm going to answer a question that was sort of asked, in that sometimes it's not easy for us to tell if someone has NMO or MS. or MS and another autoimmune condition, or NMO and another autoimmune condition. And that's because if someone has optic neuritis and it was bad and they didn't recover so well, and then you look at the lesions and they kind of look iffy, where they can be MS, they can be NMO when you're not sure. You test for that aquaporin 4 cell-based assay and it comes back negative. And then you're stuck. Okay, well, I have someone that can look like MS, look like NMO, but I'm not sure. Then we have medications that overlap between the two conditions, and that would probably be the best strategy, is let's give you something that could work if it's this or that. Because many MS medications can worsen NMO, but a few of them would work in either way. And so it would be best to sort of go with these types of medications. So in NMO, we said there's no progression. And so the goal of our treatment is decreasing or stopping relapses altogether. And then we don't want to see any other activity on MRI. Now, in terms of seeing MRI activity, there's debate amongst the NMO experts whether you do need to do a routine MRI and look. Some will tell you yes, some will tell you no, or whether patients will develop MRI changes without having any symptoms. That's debatable. So again, we are not changing symptoms when we put patients on disease-modifying therapy. We're addressing the immune system, not the nervous system. And then the repair, we still don't have repair mechanisms, and we can't reverse disability so much once it happens. So now let's talk about myasthenia gravis. Okay, so another autoimmune condition, but this one is very different than what I just talked about. So in myasthenia gravis, we are no longer focusing on the brain and the spinal cord. This is a condition that affects the periphery. Okay, so it's motor function, arms, legs, eyes, anywhere where there's muscle, throat. So all the muscles throughout the body, the immune system will attack the connection between the nerve and the muscle. So a good analogy with this would be is basketball or soccer, okay? Where you've got a ball and you're trying to shoot the ball and you want it to land so the signal can continue, or you're passing a ball to someone else. And then you have an antibody or an immune system that's blocking the receptor that's supposed to receive the ball. So then you're trying to throw a ball and the other side is not getting it, okay? So it's an immune system that's attacking the acetylcholine receptor. The acetylcholine is the little chemical in red that you're seeing that gets sprinkled, and then the muscle will receive that acetylcholine and continue the signal. So the antibodies will block those receptors so the signal can't get through. And so because of this, you're getting symptoms directly related to the immune system blocking the signal. So then the symptoms can be muscle weakness, fatigue, droopy eyelids, blurry vision, double vision, a limited facial expression, difficulty speaking, swallowing, chewing, trouble walking. So you say, well, wait a minute, those are symptoms that are similar to MS or NMO. So there is a difference here. Because we're working on the connection between the nerve and the muscle, this is something that's very dynamic, which means that I can wake up in the morning and I'd be better. And then as the day is progressing and I'm using my muscles more and more, I get weaker, 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 because that receptor is not working that well. And so it's tired, it's exhausted, and so the symptoms happen. But if we rest and feel better, then the connection is working again. And so the symptoms fluctuate on a day-to-day basis. Whereas in NMO, MS, and MOGAD, the symptoms are directly related to a destruction of the nervous tissue that's happening. So we tell patients, when you have symptoms, we're thinking, is this a relapse? We wait 24 hours. If 24 hours pass, symptoms have not changed, they're still there, okay, that's probably going to be a relapse or an attack, because we basically destroyed the network within the brain and the spinal cord. Whereas in myasthenia gravis, it's a dynamic thing that changes. And we have several medications. Some of them are older immune suppressants. that we had used off-label to treat myasthenia gravis, or on-label. Some of them have indications. And then we have newer medications, Ultomiris, Soliris, Ultomiris. Those are NMO drugs that also are indicated for myasthenia gravis. And then we have a few others, whether they work on complement or FC receptor blockers. And so those are different ways of treating myasthenia gravis. And so in this case, what we're looking for is a little bit different. So when I ask patients how they're doing on treatment, my questions are a little bit different than MS and NMO because of how the immune system, what the medication is trying to do. So the medication is trying to stabilize that junction, take away those immune markers so that they're not blocking. So then when I throw the ball, it lands. And so directly by stopping the immune system, the patient will function better because the nerves are still there. The nerves are working. It's just the connection is blocked. So that's the difference where you can directly make an impact by addressing the immune system. You can directly make an impact on the quality of life of a patient. So I talked about a lot of things, and I don't know if it's 45 minutes or less, but we reviewed the current MS medications, what we use, how we think about it, the approach. We talked about progression in MS, and then we talked about upcoming trials for medications that are addressing progression. We talked about NMO and MOGAD and how similar or different they are to multiple sclerosis, and then myasthenia gravis and how different it is, and the treatments for all of these different conditions. And I'll take questions.
I have a few questions. Is PIRA this? If you're experiencing that, does that mean you have secondary progressive MS?
So the best answer is that we are moving away from those designations. It's all one disease. It's not that you're this and then that. There's no switch that's being flipped. And so it's a continuum. Whether you're meeting the person at this stage or that stage, it's just part of the disease.
Excuse me. The way I was diagnosed with MS, I had optic neuritis in my left eye. I get on medication. The next year, I added in my right eye. And you were talking about the NMO whatever and optic neuritis and all of that. When I was diagnosed with optic neuritis, I was told that 95% of the time, if you have optic neuritis, you have MS. Is it a possibility that I would have MS or the NMOSD?
So keep in mind is that it's really challenging to answer specifics to a person or a case because we don't have the data. But certainly there's always room for revisiting diagnoses when a clinical course does not meet expectations. And so talk to your healthcare provider about that.
Yes, I know Karen mentioned that she asked if, when you suggested research, if you would suggest this for your own mother, and you said yes. And so I was just wondering if you could give me kind of some details about why you're confident in the research and doing a research trial.
So great question. I often get asked this about my colleagues in terms of, well, how do you recruit patients for trials and why are you doing trials? And you have to understand what you're doing. And so it's easy to just say clinical trial, but why are we investigating this? What is the reason behind it? And what are we trying to prove? And like I said, when you have a product that you are optimistic about, that it's going to treat the disease in a different way than what you're doing. We're doing a great job right now, I would say, in managing MS, NMO, MG, and everything else. But what if we could do it better? What if there is a way to get the same treatment, but maybe with less risks, less side effects, or a new mechanism because we know we can't touch progression with our currently available medications? And so what if we can investigate a newer one? And so I can't, in all conscience, offer patients a clinical trial that I wouldn't take myself or have a family member or a mother, take. And so if I'm going to offer this to you, I certainly am going to offer it to my mother.
So I have a question to bounce off of that one. How do you get more diversity in your clinical trials?
Please sign up for clinical trials. What's important to understand is that patients tell me, well, I don't want to be a guinea pig. But if everyone said that, then there wouldn't be trials and we wouldn't have medications. Then the flip side of the equation is patients that say, well, I don't want to enroll in a trial, but then, a lot of our trials, they don't have a lot of minorities. And so we have data from the trials that show that this medication works. But did we prove that this medication works in someone like you? So unless you sign up for the trial, then we can use you as the basis as, oh, well, it worked in this person, which means that hopefully people that have, the same background, ethnicity, they're able to improve or benefit from a similar treatment.
So my question was, so how do you differentiate between these eye conditions and like something like Sjogren's?
So conditions like Sjogren's, they affect the connective tissue. So we're no longer in the nervous system, but they're in the connective tissue. There is a crossover where some peripheral autoimmune conditions can affect the nervous system. The first things first is, like for example, an optic neuritis. To call something an optic neuritis, you have to prove that the optic nerve was inflamed. So the letter acuity, how far down the eye chart you can go, how you see color, what your nerve looks like in reaction to light, or how far out you see and whether there's a deficit, and then what the nerves looks like, whether it's swollen or thinned out and atrophied. You put all that together and then you say, okay, well, this is optic neuritis. Then depending on other markers, you say, well, how severe is this? And in what context do we think this is? Now, if someone has an optic neuritis, for example, but they don't have any MRI lesions that look like MS, they're aquaporin 4 negative, that cell-based assay does not come back positive, MOGAD is not showing up, then you say, okay, well, this is maybe just optic neuritis. Now, if someone was tested for Sjogren's and they are positive for Sjogren's, then there may be an association where someone has developed a Sjogren's-associated optic neuritis.
Anything else?
And then I watch Pam Bertha a lot. Like, do you kind of consider like parasites and trying to like, treat the parasites versus always going to the medication?
Well, we don't have proof that there's a parasitic process behind this. And so you could see in my presentation, we don't have anything that ties into exposure to parasites. So we actually don't know the exact mechanism of how multiple sclerosis starts. But we do know that it's a combination of factors: race, where you were raised, your genetic background, vitamin D deficiency, lack of exposure to sun, smoking, obesity, and having first-degree family members. So there are a lot of factors, exposure to Epstein-Barr virus. So there's a lot of factors that can contribute to MS developing. There's no strong link to parasites, and so we don't have anything proven that would make a difference.
Thank you.
So I don't know if you mentioned any about myelin repair. What's the progress there? What's the hope?
We've had several medications that were investigating myelin repair, and one was promising 7 years ago, I want to say, where it showed that it's able to improve the signal in the optic nerve. But then when they tested it in relapsing remitting MS, it didn't make a difference, and that medication did not pass. There are some, repurposing of medications. Like there's an antihistamine, clemistine, that was tested for myelin repair. It showed some promise. The problem is that either the treatment is not strong enough to be able to make an impact or make a difference, or our ability to measure that repair is also not that great. And so we have some, but still nothing promising, ready for prime time.
Great. Thank you.
Hey, first of all, thank you. That was a great lecture. I love how easy you explained everything. So thank you for that. But With the new McDonald criteria for diagnosing MS, they have RIS, radiologically isolated syndrome. Most patients will eventually develop MS with that. Would you be treating them immediately, or would you wait until they actually have symptoms, because they do have the lesions but no symptoms? So what would
Yes,
you do?
for a while now, actually. So RIS is, let me explain it. So if right now I'm walking outside and I trip on the pavement and I hit my head, go to the ER, they scan my head and they find lesions that look like MS, but I've never had a symptom of MS. That's RIS, is when the brain looks like MS, but the patient has not yet had symptoms. So we now think that this is a precursor to MS. If you wait long enough, at some point, this person will have an episode and that will lead to an MS diagnosis. And so why wait if you know that this person is going to develop MS at some point? And we've updated the diagnostic criteria. It's actually not yet been published. We've talked about it. They've discussed it in our latest meetings. The paper is still yet to come out, but improving the diagnostic criteria so that RIS is included and we're able to diagnose it with MS. I have treated patients with RIS. If I feel like they are active and they are for sure going to develop MS, I have treated them. Yes.
Thank you.
I know you mentioned you guys are going or trying to go away from designations of different types of MS. Is there a specific reason why there's not many medications offered to people with PPMS versus the other designations of MS?
It has to do with our ability to capture. If you go back, and this is a little bit on a higher sciencey level, but if you go back to a lot of the trials that have been done on progressive MS, and some of it, they may have failed because of how we designed the trials, not necessarily the drug, but it's how we designed it. Because again, it's, okay, well, I know that there's a change, but how do I capture that? How do I prove the point that I'm trying to make? And this is where, with time, we're improving our markers and trial design so that maybe we're able to capture some of those. And so the short answer is that we either have not been able to find a medication that really truly slows down progression, or that we're able to kind of capture that change.
Okay. You haven't discussed anything. I'll be there in a second. You haven't discussed anything about smoldering MS, and people online are asking about smoldering MS. But in addition to smoldering MS, is there a smoldering NMOSD or a smoldering GMS or MOGAD or anything like that?
Okay, I didn't use the word smoldering MS, but everything I was talking about is smoldering MS. So the PIRA, the progression, the compartmentalized inflammation, that's all smoldering MS. It's basically you've got this MS that's smoldering in the brain compartment, and we can't reach it. And so I don't know that we necessarily have smoldering NMO or GMG. Just because it's a different mechanism. A lot of the what we believe the mechanism behind the smoldering MS is it leading to progression, and we don't really see progression in those other autoimmune conditions. This seems to be something unique to MS.
Thank you. Another one is about the optic neuritis. Similar to the question being asked about getting it in both eyes, a person wants to know why he is getting it often, like every couple of years he's getting optic neuritis. And is there a reason why that might be happening?
Okay, I'm not addressing the person directly who asked the question. We're going to keep this general. If someone has had a recurrence of optic neuritis, or if someone has had a recurrence of any MS symptom or NMO, there's nothing called classic in MS and NMO, okay? So whenever you say, oh, this is the same leg every single time, the same eye every single time, that means that it's probably a false or a pseudo relapse or attack. So I'll give you another story. I've seen a patient who has had optic neuritis multiple times, supposedly diagnosed with MS. This person does not have MS, never developed optic neuritis because it was all migraine. And again, so the take-home message that I'm trying to deliver here is that if something is happening over and over again, something is off. Okay, we need to investigate. It's either maybe it is recurrent optic neuritis. That means the medication is not working, or maybe it's a pseudo relapse. That means that okay, we need to address the underlying cause, or maybe the diagnosis is completely off.
So I know you mentioned the difference between the targets of attack between NMO and MOGAD, but you know how they differentiate NMO by the positive aquaporin 4. How do you differentiate NMO and MOGAD, like when doing diagnosis?
Yes, so we think that so when someone has NMO symptoms, a long myelitis or a severe optic neuritis or some of those other areas that are affected, you send for that aquaporin 4 antibody, the cell-based assay, and so 20% of patients will be negative for that assay. 80% is positive for that antibody, 20% is negative. Within that subset, then MOGAD, will be positive. So if you have someone who's positive for aquaporin 4, this is slam dunk NMO. Okay. If someone is negative for the aquaporin 4, then you check them for the MOG antibody, and if you find it being positive, then that's confirming MOG.
And then my last question is on the PIRA. So if they're not having any like relapses, how do you measure the progression?
So you're talking about MS or NMO?
It was for MS, yeah.
For MS? Well, that's what I said is about the different markers. And so clinical tests to see is how a person's performance is, how they do on their walk, their arm function, their brain function, and you try to capture that with your numbers to see is okay. Well, is it really changing or not?
Thank you. Next one.
Early on, when you started talking, you mentioned something about vaccines, and we've had a lot of them lately, and their effectiveness, whether they're actually work or not. Is there any specific medications that are out for MS that you're aware of that would keep the vaccine from working?
So the quick answer is no. Most MS medications will decrease the vaccine response, but there will still be a response. Okay, for most drugs, some of it may depend on the timing of the vaccine. Some of it depends on other factors. Keeping in mind is that when someone is on immune therapy, we don't want live vaccines. Inactive vaccines are okay. If I think about nowadays, the main live vaccine that would be a concern is the measles. Other than that, most of our vaccinations are inactive. The flu, the COVID, the Shingrix, all the other ones, they're inactive. And so the response is dampened, but it's still there.
So would there be any other reason why it didn't appear that the COVID vaccines did anything for me? Because my doctor had blood tests run for some type of protein thing she was looking for, and I never developed it.
So I can't answer specific cases.
Right, I know. I'm
Right.
just
So
in general.
yeah. So the lack of response does not mean lack of effect. If you don't find the antibodies, does not necessarily mean that you did not mount a response.
Thank you. Next one online. Do you do telehealth? And if so, how?
Where's Amanda? Yes, we do telehealth. Go to our website, neurologydallas.com, and somehow contact our office and they'll connect you with telehealth appointments.
Do you know the person does not have to be from around here? That everybody should know that. So I don't think that he's going to be happy that you were laughing at him.
Oh,
I'm
sorry.
joking.
Yeah.
All right.
I still have a Florida license. And
I
so might be a
I
licensing
happen
issue.
to know who the person is, and he's always got questions. So, all right. The next one is that from a person that happens to be in a rural area, and they want to know if she lives very far from a MS center, and what other ways are there for her to be treated if she needs to see somebody? She doesn't believe in telehealth, she says.
Okay. I always welcome second opinions and second checks because, you never know. When you have a serious disease like MS, NMO, MG, you want to make sure that you are getting treated the right way at the right facility. That being said, it's not always possible to have access to proper care. And so what we sometimes do is we work in conjunction with a local provider. And so if it's prohibitive to see an MS neurologist often, then maybe we can create a recipe and then have the local neurologist follow that recipe. And so then the consultation is infrequent, but you have someone who's able to follow along.
Great. Thank you. Next question. When do you consider age to be a factor in getting treated?
Well, that differs as the years go on, and I'm getting older, and so now I'm rethinking my aging strategy. Just kidding. So you have to see, again, it's not an age thing. It's how long you've had the disease, what the clinical course has been like, how many relapses, what kind of progression, and then depending on where someone is in that journey, you decide what kind of a treatment they need based on where they are in that journey. And so the answer differs from person to person. I diagnosed someone as young as 4 years old and as old as 72. So activity can happen at any point in time. Yes, the bell curve will be mostly 20s to 50s, but then there are a lot of people that are outside the bell curve. And so you can't just create a cutoff point.
Okay, thank you. Next one is, where do you send people that need more resources for NMO? And as long as I'm saying that, where do you refer them for whichever other of these rare disease states? Where can you tell people to go to?
Clinicaltrials.gov. If any person right now, you can just go into that website and it has a filter. So you can put your disease, you can put the phase of the trial that you're looking for, or the medication that you're wanting to investigate, and it will give you, or you can even filter it by active sites that are recruiting or non-active. It'll show you everything around the globe, and then you can find the sites that are running that trial based on this, and then it'll give you the contact information for the people there.
Thank you. This wasn't based about trials, though. This is about resources to do with like symptom management.
Okay. You'd find a lot of benefit from your nonprofit organizations, MS Views and News, National MS Society, MSAA, all the other ones, MS Foundation. They have good information in there that is reliable and trustworthy from experts who understand the conditions. And that way it's not Dr. Google and some random blogs and websites.
Thank you. Next one is, the question is stated as, we know a lot about MS fatigue, but what can you tell us about fatigue in NMOSD?
Yeah, whenever you have a condition that causes damage to the nervous system, for sure fatigue is going to come and play a role. It's one of the most common invisible symptoms of the disease. Now that being said, having demyelination and destruction can lead to fatigue, but a lot of other factors can lead to fatigue as well, depending on someone's mental state, how they're feeling, depending on someone's sleep patterns, depending on someone's activity level, other medications, other conditions. So there are a lot of factors. And so whenever someone mentions fatigue, then before I address that real quick, I have to go through all these different things and see what is playing a role to try to see how we can help mitigate that fatigue to the best as we can.
Great. Another one writes, concerning multiple sclerosis, what do you say to people who have swallowing problems when swallowing food, I guess, and what do they do about it?
So, we often get asked about swallowing problems. First thing is diagnostics. And so someone has to undergo a barium swallow where they watch you drink a contrast material and they see how the throat is moving and whether it's actually clearing or not. We need to work closely with ENT as well to kind of investigate the pharynx and the larynx. Take a look at all that mechanism and see if it's working or not.
Okay. How do you tell a person when the best time of day is to exercise if heat is a condition?
Well, there's always exercising indoors, and so that's a way to avoid the heat. There are cooling vests that patients can use that will keep them cool. Ice water is helpful, keeping that internal temperature cold. Swimming is great because not a heated pool, but a regular pool, because that's cold and then you get to work out your body. So there are ways around it.
Okay. Person writes, I live in a rural area. My doctor only believes in one brand of medication, and I know I need something else. What do I do?
Seek a second opinion.
Yeah, exactly. All right. Next, a person writing about visual problems, that a stinging burn that just comes and goes, and it's like a match touching the eyeball. And what is this?
So any kind of damage to nervous tissue can cause neuropathic pain. That neuropathic pain, if it's in the eye, it's going to cause similar symptoms. If it's elsewhere, arms, legs, feet, it'll cause neuropathic pain elsewhere. The approach would still be the same in trying to use neuropathic medications that would quiet down some of that pain. Whether it's the gabapentinoids, the tricyclic antidepressants, or the non-selective SSRIs, those are all medications that can work on nerve pain.
Okay. Next one writes, I'm afraid to tell my boss that I have MS, but every afternoon I get very, very tired and I need to sit down a lot. My boss yells at me. What am I to say?
So I can't answer specific cases, and this is a very specific case. In general, I will tell you that maybe most of my patients have informed their work situation about their condition, and then I have a few that I remember off the top of my head that opted not to tell. So that's a case-by-case basis. It all depends on the what you need, the help, the support that's available, and so that's something for each person to consider on a case-by-case basis.
All right. Back out here.
When you were discussing the research medications and how the FDA takes into account the number of relapses that that a medication prevents, I guess, I'm wondering if other factors like side effects or the amount of the immune system that is inhibited are taken into account too.
Yes, we have examples of medications that have proven efficacy, but they were held back because of safety concerns. So that has happened in the past.
You mentioned earlier that with NMO, if I understand correctly, is that there's no progression. It's just kind of like we're just kind of waiting if there's like an attack to happen. Is that correct? So, if did I understand that correct?
Right. So from what we've seen in NMO trials is that patients will just have relapses and they go away, relapses and they go away. Now they may be left with a devastating outcome after the relapse, but there's no slow decline that happens over time.
And in regarding also one of the for NMO, you mentioned something about not being under the heat a lot. Is that did I understand that correctly?
Heat sensitivity is common, whether it's MS or NMO. Again, once you have that demyelination, the stripping of the myelin, so the nerves are sensitive to heat.
That being said, do NMO patients also, can some of them get cold sensitivity?
Yes, that's also common.
Okay.
I have a question about MS. In the presence of MS and DMT, basically therapy, is there any risk or something to know about blood transfusion?
Meaning donation?
No, getting blood.
Getting blood. Technically, well, I mean, that's a complex question. It just depends on. In broad ways, no, there isn't. So they would kind of cross and match, and so it should be okay.
As a patient who needs to get blood and I have MS, is this something that I need to inform my neurologist before, or how I can go about it to minimize the risk?
So no case-by-case questions.
Sure.
In general, every patient should discuss everything with their MS neurologist. They need to know everything because some things may not be obvious, but there may be interactions with medications or the conditions.
Thank you.
Okay. Retrospectively, how come if I go to a Red Cross van to give blood and they find out I have MS, they say no?
Do you want to give them your autoimmune cells that are attacking your nervous system?
Yeah. I do.
not a good idea.
Okay. I hold the mic.
Okay. Okay, this is to the gentleman down there about when is it time to tell your boss. If you don't tell them, they will find out. I didn't tell mine, but they found out because something happened. I worked for the Department of Corrections in California, and I was in charge of the women's count. You know, just on paper, and that's when the optic neuritis came in because it was flipping over numbers. I had 8 looked like a 5. You know, so I let out 1,000 people, women from the prisons. You know, the other uppers came running to me, talking, "Kim, what did you do? What did you do?" I said, "I just, did the count, the women's count." And they said, "Yeah, but you let a lot of people out of prison." And 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 so they will find out. They will find. I had to tell them. That, that 8 looked like a 5. So I had to tell them why it looked like a 5 and it was an 8. And so they will find out that, sooner or later they'll find out.
Okay, thank you. Question?
I'm hearing all of these things about.
Well, you need to speak again.
Okay. I'm just hearing a lot of these nuances, for lack of a better word, of talking to your boss about your disability. I mean, there are laws in place for that. So, American Disabilities Act, Public Law 94142, there are laws against that. They can't fire you because you have multiple sclerosis or bipolar or anything like that. You go through your HR department. I mean, I know, at least for my company, they actually have a department called Employee Relations. You talk to them about your disabilities, and if it's a good company, they'll work with you on your disability, but you should never have to be quiet.
It's great. Thank you.
Hi, good presentation. Thank you. I wanted to know, what is the progress on technology reading MRIs?
Yeah, so with the development of artificial intelligence, there are a lot of companies that are trying to create automated softwares where they can pick up on new lesions that have developed. And so there's a lot of models out there that we've seen. I think it's still not ready for prime time. And so, but certainly can be a tool that's added to the mix. So it's certainly advancing. The imaging factor is getting better.
There are certain hospitals and places working with a company called Icometrics that are doing splitting of all the tissues and et cetera, and it's all AI. And it's winds up. It's great for the medical industry to know about this new research, and it does happen also with the MRIs at Memorial now. Back in where he used to work, all right, where they, if I went in there for a scan, I mean, the results are out in 20 minutes, all right, and they know everything about what's going on in my brain more so than I've ever seen before. So it is pretty amazing what's going on with the new AI technology. So I would look for a big hospital system to get, to go to get your scan though. So.
What does stress contribute to this? I mean, I feel like that when we get stressed, everything goes a little more crazy. Why is that?
Well, stress is pro-inflammatory, and so a lot of inflammatory cells will become overactive. And so when someone is under stress, it'll also overwork your brain. And so when your mind is distracted by the stress, then there's less power going to other parts of the body that are functioning. And so there's multiple different ways on how stress can impact the nervous system and the immune system.
All right, that's it. So we're going to call it a wrap. All right.
Thank you.
Got that done very nicely. Perfect. Thanks for doing this. Thanks for asking us. So again, I want to thank our sponsors for today's program. We had Alexion and EMD Serono as our program sponsors, and I want to thank them, and I hope that you all do as well. And I can't do these programs without all of you, so we hope to see you when we are going to be back here in a few months. We're going to come back to this same location to do a program. Have a great day, everybody.